Then we're going to have the grand round this Wednesday. It's going to be Dr. Junkins, that again is the director here of microbiology at the Norton Healthcare. He's a member of our Norton Infectious Diseases Institute, and the topic of this grand round to me is an example of what we try to do in this grand round. It's a combination of practice, but at the same time, infection control, infection prevention, antimicrobial stewardship, and probably one area that combine all these elements are the challenge of urinary tract infections and the primary role of urine cultures. Then this is going to be the topic of today, blending all our interests. Then Alan, thank you for this presentation. All yours.
Okay, thank you very much. Happy to do it. But honestly, I sat around last week listening to the talk on monkeypox and said, oh, come on, you can't do something as mundane as urine cultures to follow that up. But we're doing it anyway, okay? So this is why we need to talk about urine cultures. First of all, we do a bunch of them. I think in every laboratory in the country, the #1 type of specimen cultured is urine. At our place, right at half of all cultures are urine cultures. So that's 300 a day that we're doing, mostly from outpatients. So those of you who are hospital-based, it's a kind of a different thing between hospital and outpatients, but we do mostly outpatients. If you look at the literature, there's a lot of new information in the past decade or so about how we should be working up and how we should be reporting urine cultures. People have talked about how much bacteria do you have to have in a urine culture before it's truly significant, or what's the difference between different types of patients as far as what is clinically significant in their urine. And that's troubling, because if you look at our actual procedures, how we go about working up a urine culture and interpreting it and reporting it, things haven't changed. We haven't done anything differently for a long, long time. Our procedures aren't aimed at different patient groups. We can't do that. We can't customize for a certain group of patients. We have to write procedures that fit most, which really in this case is acute cystitis in outpatient women being the main thing. And there's so many of them that any change in procedure is going to be amplified. So if you say, well, you need to add one more plate or one more plate read, well, that's 300 more plates a day for us. That's a big ask. Any small change in workload is going to be a very big ask. And for all you infection control people out there, I'm going to talk about this a bit. I hesitate to do it because I'm probably going to get it wrong. But you sit around and you count all these CAUTIs, these catheter-associated infections, based upon the microbiology results. The microbiology procedures need to be compatible with those definitions, or at least you need to understand how what the lab is doing might be affecting whether something gets counted as a CAUTI or not. So let's start off with the main thing. We do a lot of urine cultures. Do we do too many urine cultures? And I think you can probably look at most of them and say, yes, we do too many urine cultures. And I'll give you 2 examples of that. Like I said, most of what we do is acute, uncomplicated cystitis in females. If you look at the family practice guidelines for how a family practice doc, a general physician is going to treat a patient like that, the guidelines say, don't culture. You don't need to culture that. You have a woman who comes in who's got cystitis, you treat them. Treat them empirically. It's going to work just about every single time. If she doesn't get better, if the symptoms persist, or if she gets another UTI, if it keeps recurring, then you need to culture to find out what's going on. But then in that case, it's not uncomplicated anymore. Now it's a complicated urinary tract infection. So I know good and well that a whole lot of those 200 outpatient urinary tract infections, urine cultures that we do every single day, are uncomplicated cystitis in females, and probably we should not be culturing those. And also, we'll talk about asymptomatic bacteriuria. This is the big deal right now. You're not supposed to treat that. The guidelines say do not treat asymptomatic bacteriuria. And of course, a culture is not going to be able to determine that. A culture is going to be able to determine whether there's bacteria there or not. It's not going to be able to determine whether the patient's asymptomatic or not. That depends on the people ordering the test to say that. So if your patient is not having any symptoms, if they're asymptomatic, there's no reason to culture, generally. Now, I know this looks a whole lot like an alien, but this is the best I can do with my artwork. This, if you look a little closer, this is your bladder. Okay, here's your bladder, here's your ureters, here's your urethra. This is my little diagram of how we decided on how we'd go and work up urine cultures. This is what it normally looks like in an uninfected individual. The bladder we consider to be sterile. Now, I know there's lots of microbiome research out there now which says that that's not necessarily the case, but that's for a different day. Basically, the way we think about it is that urine in the bladder should be sterile. But down here in the distal portion of the urethra, you're going to have skin bacteria, GI bacteria that are going to make their way in, and they're going to colonize just the anterior portion, or the distal portion, whatever this is down here at this end of the urethra. They don't make their way up because, every couple hours or something, there's going to be a big gully washer come through that washes most of them out. But there will be some colonization right in there. Different types of bacteria. If someone is infected, then this is what we'd expect to see. That same normal flora down here at the bottom, but in the bladder, you're going to have a lot of the pathogen. So a lot of a single organism is going to be what we see with a UTI. So after you collect a specimen and send it to us, this is what we should be seeing. If the specimen was collected well, if it was clean catch, if it was midstream, if it was held properly, it was refrigerated, it was put into a transport medium, or we were able to get it very quickly in the laboratory and set it up, then an uninfected urine is going to have very low numbers of a few different types of bacteria. Whereas infected is going to have that same normal flora is going to be in there, but you're going to have a lot of the pathogen. So that when we do the culture, it's very easy to look at it and say, this is infected, this is not infected. And it's very easy to say, if it's infected, this is the bug that's causing the infection. Then you have this situation. Urine is a decent growth medium. It's not a great growth medium, but it's a good growth medium. A lot of bacteria will be able to grow in urine if they're kept out at room temperature too long. So if the specimen wasn't collected well, if it wasn't clean catch midstream, if it was left at room temperature for too long before we were able to set it up, then what you're going to see is growth of all this normal flora bugs. So lots of different types of bacteria, but in fairly high numbers. In an infected urine, you're seeing pretty much the same thing. You've got the pathogen mixed in there with it. But obviously here, it's going to be very difficult to us to tell on the culture, is this an infection or not? And if it is, which bug is the pathogen? So that's why specimen collection, specimen transport has got to be really important. So let me go over those rules here pretty quickly. This is what we have always said. All right, we want clean catch. What that means is that particularly women and uncircumcised males need to clean the periurethral area to try to get rid of as much contaminating bacteria there as possible. Okay, you want to use sterile water for this or sterile saline for this. Don't use an antiseptic solution. It might sound like a good idea to use an antiseptic solution, but one drop of an antiseptic in that urine is going to mess up the results. So sterile water, sterile saline, clean the periurethral area. Now, I will tell you, I say, is this really important? And the reason I put that in there is because there has been a study or two in the past 5 or 6 years or so that have questioned whether this is really all that important or not. I'll just put that out there. we still don't care. We are still going to tell patients this is what you need to do. Okay, you still need to clean that area before you send us a specimen. We want it to be midstream, because remember that diagram, you had that urethral flora in there. You want to wash out as much of that urethral flora as possible. So use the first 10 mils or so of urine. I know you don't count how many mils you passed while you're sitting there or standing there, but that first little bit of urine there, use that to wash away that urethral flora, and then collect the midstream. So the midstream is going to be that urine that was in the bladder and should have pretty much just that bladder flora in it. And I want to point this out because this is something it's a constant problem. You should never do both a urine culture and a molecular assay for gonorrhea and chlamydia on the same specimen. I know they're both urine specimens, but for the urine culture, it needs to be clean catch midstream. For the molecular assay for STDs, it needs to be dirty catch, first void. So those are two different types of specimens. If they send one for urine culture, if they send one specimen for both urine culture and molecular, you know one of those is an inappropriate specimen type. Then getting it to us. Ideally, what we want to see is it in a transport medium. So similar to this, these gray top vacutainer tubes, this is the urine CNS vacutainer tube. It's got some preservatives in it that are going to not let the bug grow. They won't be able to grow, but they're not going to die from it. Okay. You look at other preservatives, what we call preservatives, obviously things like formalin or something, that kills everybody. We can't kill everybody. We've got to keep them alive, but we don't want them to grow. So studies have shown that these things are really good. You can have room temperature storage for up to 48 hours without any significant change in the viable microbial content of it, okay? Couple of rules though. You see here, there's this minimum fill line. You got to fill up to the minimum fill line. The reason that's there is if you put less urine in there, you're going to have too high a concentration of boric acid and sodium formate, and that will kill the bacteria. So make sure you get to that minimum fill line. And secondly, the urine tubes that are labeled urinalysis aren't good. They're not going to be useful for culture. So it runs into a bit of a problem. We'll talk about reflex later down the road here. But, when you have a single specimen that you send for a UA plus reflex, the urinalysis tubes are not going to be good for the culture part. So you've got to make sure that you really send the appropriate specimen there. In a hospital setting, you can just send the urine down and the lab will take care of it. But in an outpatient setting where you're sending it to another laboratory, typically you're going to have to send two tubes. Okay, one for the UA, one for the culture. And then the other option to the transport medium is to refrigerate it. So basically, here are the options for getting the urine to the lab. Fresh urine, unpreserved, just in a urine cup, can be at room temperature for up to 2 hours. Once you get beyond 2 hours, you're going to be letting bugs grow too much, and your colony count is going to be wrong. Like I said, a transport medium, room temperature for 48 hours, or refrigerate it for 24. Okay, any of those will be fine. Now, when we culture a urine and when we look at it, these are pretty much the rules that we kind of use for interpreting those results. We don't streak by the four little colonies, by the four little quadrants that you think of when you streak microbiology plates. We streak for colony count. We use a 1 microliter loop. This is a loop has been calibrated so that it's going to pick up 1 microliter of urine, and we spread that urine over the entire plate. Then we can see how many colonies are on that plate and multiply it by 1,000. And then it gives us the number of colony forming units per mil. We never use bugs per mil. We always say colony forming units because you think of something like a staph. If you have a cluster that has 5 different cells in it, it's going to form 1 colony. That's 1 colony forming unit. It's 1 cluster, 1 colony forming unit. True cystitis. Somebody who really has an acute cystitis is almost always going to be a single organism with a colony count of greater than 100,000 CFUs per mil, greater than 100,000. Almost always that's the case. Then you get into the gray. Well, let me go over here. Less than 10,000 CFUs per mil is typically not considered clinically significant. That's probably just urethral contamination or flora that got in there. Okay, so these are kind of the straightforward ones. 50 to 100,000, or I can even say 10,000 to 100,000 is the gray area, kind of equivocal. In some populations, that might be important. In others, it's going to be considered contamination. And we'll get to that in a bit too. But I can almost always say this: if you have lots of different organisms with a high colony count, that means that really looks like a poor specimen collection and or poor transport. So those are the ones where we send you that little report that says, mixed flora, we're not going to work this up. Try again. Now, another issue is that urine is not just urine. It's not the same thing. We already mentioned that first void urine being used for nucleic acid amplification is a different issue. But for urine culture, we do separate them. And the way we do it here is we say we have non-invasive urines and invasive urines. So this is how it was collected. A non-invasive urine basically is going to come out through the urethra or through whatever hole you've created for it there. So all of these are non-invasive urines. They are going to have normal flora in them. They're going to have some urethral flora, or in these cases, they're going to have some flora that's colonizing that stoma. Streak those with 1 microliter loop. So 1 colony on the plate is 1,000 CFUs per mil. We can detect down to 1,000 CFUs per mil. These ones we consider invasive urines. A straight cath or an in and out cath, a suprapubic aspirate going right through into the bladder to aspirate out the urine. Those are going to avoid any contamination with the urethra, with normal flora, with a colonized catheter. So there's going to be a lower threshold for clinical significance. You're basically kind of saying, if we get a bug from here, we really think that this bug is in the bladder, not in the urethra, but in the bladder. So those get streaked with a 1 microliter loop, but also a 10 microliter loop. So 1 colony that on a plate that was streaked with 10 microliters is 100 CFUs per mil. So we can get down to 100 CFUs per mil with that. Okay. So here's some examples of things that we have seen over the past few months. This one here, you don't see much going on here. Okay. I didn't show you a picture, but one result that may come out of these is no growth. But if you look at this one here, you've got this 1 colony here, pretty obvious. There's another colony right there. And there's a third one over there. Those are 3 different bugs. Okay, so this we would call, that's 3,000 CFUs per mil. We don't report 3,000. We're going to say less than 10,000 CFUs per mil, and it's mixed flora. And that's all we're going to do. We're not going to work up. We're not going to identify these organisms. We're not going to do susceptibility testing on those organisms. We're going to say this is less than 10,000 CFUs per mil, mixed flora. It's not real. It's not an infection. Okay, move on. Now, at the opposite end, we'll see something like this. All the colonies are smeared together. I can't really count how many are there, but I know good and well that there's more than 100 colonies. So therefore, there's more than 100,000 CFUs per mil. This turned out to be E. coli. So you can look at it, and this is what you're seeing in here. This is a clear infection with E. coli. You look around, you might be able to see another colony or two, but it doesn't matter. The E. coli is the important thing. Here's another one that's kind of in that gray zone. Only 1 bug. So definitely you've got a predominant organism. It's somewhere, I don't know, I'm going to guess somewhere around 20,000. So we're going to report that as 10 to 50,000 CFUs per mil. This ended up being a Klebsiella. So again, this is suggestive that this might be an infection. We're going to report that name. We're going to do susceptibility testing. But since the colony count is kind of on the low side, it needs to be interpreted by the physician. Is this real? Is this really an infection here or not? Then you get things like this. Okay. Now, first of all, overall, clearly more than 100 colonies, so clearly greater than 100,000 CFUs per mil. But there's lots of different things here. There's 1, 2, 3, 4. There's like 5 or 6 different organisms here. You can even see some bigger guys up in here. There's a bunch of different bugs here, and nobody predominates. There's no one here that really stands out as being the cause of an infection. So this is probably normal flora. It was not clean catch, it was not collected well, or it was not transported well. And so we can't tell what's going on. So we're going to report greater than 100,000 mixed flora and put a comment in that says something like, we suggest if you really think this patient has a UTI, then you collect again, because we can't tell from this what's going on. I put this one in too, just as kind of cool. This is a lower level, but it's still mixed flora. I count 14 colonies on this plate. And at least 6 different colony types. So this is still, it's in that equivocal range, 10,000 to 50,000, but it's all mixed flora. There's nobody predominating here. And don't look at this colony and think, since it's bigger, it must be the one that's causing the infection. It has nothing to do with the size of the colony. It has to do with the number of colonies. So again, repeat it. And this one in here too, this is a cool one. This is a McConkey plate. So you're only looking at gram-negative rods here. There's greater than 100 colonies, so greater than 100,000 CFUs per mil. But if I look at this, you got the pink guy, you got this dude, you got another one. You can see the difference in color up here. These are 2 different organisms. You got this little teeny guy here as well. So you have at least 4 different gram-negative rods on this. This is probably a colonized Foley catheter. We're not going to work these up. We're not going to report them by name. We're not going to do susceptibility testing. The way to get rid of this is to change out the Foley. That's the way to do it. Now, here's the part where I really didn't know if I should bring this up, because you guys are a lot smarter at applying infection control definitions than I am. But I wanted to bring up to make a point, okay? And that is that you really should get together with your microlab and figure out how they work up cultures. How do they go about deciding what to report? Because it will affect your CAUTI rate for better or for worse. So these are the definitions that I stole, from this CDC document, or NHSN document, came out in January. The laboratory criterion. Patient has a urine culture with no more than 2 organisms, 2 species of organisms, at least one of which must be greater than or equal to 10 to the 5th. That's greater than or equal to 100,000 CFUs per mil. And then over here, mixed flora is at least 2 organisms. If we call it mixed flora, that means there must be mixed. There must be at least 2 bugs there. So an additional organism recovered from the same culture would represent more than 2 species. And the specimen cannot be used to meet the UTI criteria. That's one that I really think is a little crazy. So if you look at these, and please correct me if I've got this completely wrong. Greater than 100,000 CFUs per E. coli, of course, that's a UTI. That meets the criterion. But 10 to 50,000 CFUs per mil of E. coli does not, because it's got to be at least 100,000 to meet the criterion. All right. Greater than 100,000 mixed flora, of course, no. Now, here's the ones that really kind of interest me. Greater than 100,000 CFUs of Enterobacter, and then 4,000 of Staph epi and 2,000 of Corynebacterium striatum. There's more than 2 organisms that are identified. And so it is a no, even though clearly this looks like a UTI caused by Enterobacter cloacae. It does not meet the surveillance definition. And same thing, if a lab shouldn't report this, but they should have reported it as greater than 100,000 Enterobacter and less than 10,000 mixed flora. But that doesn't, because mixed flora implies that you have at least 2 organisms. So it's kind of interesting that there might be this little offset there. And the reason I want you to know that is that the way your lab interprets and reports does affect what meets the definition or does not. And I don't want you, and I don't want our people to be putting pressure on the microlab to change the way they report just to fit the CAUTI definitions better. But you need to be aware of what the differences are. For example, I don't want somebody calling me up and say, you have greater than 100,000 enterobractic cloacae. Can you look really, really hard to find 2 more colonies on there of something else? Because if you find 2 more colonies of something else, just a single colony of this and a single colony of that, then it doesn't count as a CAUTI. So little weird. Yeast don't count. 100,000 of Candida albicans, we don't care about, but 100,000 of lactobacillus, which is almost always 99.5% of the time, that's going to be vaginal flora that's contaminating the urine. That does count to meet the definition. So just kind of an interesting thing to go on. What is all of this based on? Well, I hate to tell you, but we picked this 10 to the 5th cutoff, 100,000 CFUs per mil cutoff, based on this paper right here, which is older than me. 1957 is when we did that. But in the meantime, we've got pretty much 60 years of doing it this way, and it's seeming to work pretty well. So we're very reticent to change. Now, there have been some suggestions about changing. I put this paper in here. This paper, I really like these guys. These guys are really, really smart. But they did this paper, what this is now 6 years old, and made some suggestions for how we should be working up urine cultures. And I won't go through the great details of this. First of all, they only did straight cath specimens, and they only did women, okay? But they recommended this expanded method. This is what we do right here, the standard method. That's exactly what we do. And they say that only detects 33% of uropathogens. Whatever quantity, only 33% of uropathogens. But if you did this way, you'd pick up 84%. But look at this. This is 2 plates. This is 17 plates. This is twice. My techs have to look at a place twice. Here, they would have to look at it 32 times. Now, multiply that by the 300 urine cultures that we do every day. And we would have to hire 5 or 6 more people and have many more incubators to be able to fit that in there. So they went with this, which brings it down a little bit, detects a little bit more, but unfortunately that delays everything an extra 24 hours before you get your results back. Now, there's one graph in that paper which does show this. The blue bars are those people who had UTIs. The red bars are those people who did not have UTIs. And that was based completely on asking the patient, do you think you have a UTI? So it's completely subjective on the part of the patient. But look at the colony counts here. These blue bars coming up here above 10 to the 3rd, not many coming up above 10 to the 5th. And the red bar is usually not going up that high. But on the basis of this graph, they recommended different thresholds for different organisms. For Aerococcus urinae, only 100 CFUs per mil. For group B strep, 10 to the 3rd per mil. So where we're saying right now, 10 to the 5th per mil is what we're looking for. They're saying you may have to go a lot lower than that. And here's another paper. This is from the freaking New England Journal of Medicine. So you know it's a high-toddy little paper, right? Again, premenopausal women, they looked at comparing clean catch midstream to straight cath and said straight cath is going to be the gold standard. If you get the bug on straight cath, that means there are bugs there in the bladder. And what they showed is that the predictive values of voided midstream urine were over here. This is how they correlated with the straight cath specimens. So 92% of the time, if you had only 10 to 100 E. coli in that clean catch midstream, then E. coli was found in the bladder as well. So they're recommending that you use a cutoff of 10 to the 2 for E. coli. Meanwhile, for Enterococcus and group B strep, the positive predictive values were lousy, even when it was up greater than 10 to the 5th. So even when you see greater than 10 to the 5th Enterococcus in a clean catch urine, it's probably not actually causing cystitis. So again, recommending different cutoffs for different organisms. And I'll go by this real quickly. These people are saying, don't report anything less than 100,000 because you're going to be inappropriately treating. For pediatrics, it's pretty much guaranteed now. Everyone kind of agrees that 50,000 should be the cutoff, not 100,000. And I'm just going to point out, nothing personal here, but what about men? This is all research that's done pretty much on women. We don't know much about what the appropriate colony counts would be in specimens from men. So let me finish up here with the grand old question about, do you reflex or not? I will say this, there are hundreds and hundreds of papers out there looking at the correlation between parameters on a urinalysis and whether it's a true UTI or whether the urine culture comes back looking like a true UTI. Everybody's trying to do this, and it's got some good points and it's got some bad points. The whole idea here is that we want to cut back on the number of urine cultures. We really only want to culture those urines if there's a relatively high pre-test probability. So I'm going to test this here. And if you got white cells in there, then I think, the chance of you having a UTI is shot up a little bit. So we're going to go ahead and do a urine culture. It raises your pre-test probability, and therefore your positive predictive value is going to be higher. You're going to have fewer cases, presumably fewer cases of asymptomatic bacteriuria, and therefore you won't be treating all this asymptomatic bacteriuria that should not be treated. And as a plus, it should reduce the number of urine cultures that you do. You should, with the reflex, be ruling out people that have a low likelihood of UTI, and therefore we're not going to culture. That's the plan. But it all depends upon which parameters you use. Gold, here you got it. You got to use either the leukocyte esterase on the UA strip or microscopic white blood cells. Good sensitivity. People who have UTIs are going to have these, okay? It's got lousy specificity. There's a whole lot of things that can cause you to have white blood cells in your urine that are not urinary tract infections. The nitrite is the opposite. The nitrite's got very good specificity. There's hardly anything else that's going to cause you to have nitrite in your urine other than a nitrate-reducing bacterium causing an infection. But the sensitivity is terrible. Sensitivity is probably 20, 30%. So it's really, really bad. Some use bacteria, macroscopic. If you do a microscopic and you see bacteria, then you should do a culture. No, no, no. That's what I say. Don't. Because if you have bacteria but don't have leukocyte esterase or white blood cells, that's almost the definition of asymptomatic bacteriuria. So the key parameter is going to be these white cells up here. Nitrite you can add in just because it's not going to harm much. It's got very good specificity. So you got to use the right set of parameters to use. Here's the pro, the one pro. I should have taken the S off here. The lack of leukocyte esterase or white blood cells has a good negative predictive value. You can almost rule out a UTI if you don't see those things in most patients. And therefore, you're not going to be using your laboratory too much. You're not going to be doing all these hundreds of urine cultures a day, and you shouldn't be treating people for infections that they don't have. But there are some cons. The positive predictive value is terrible. Is if you look at the positive predictive value of leukocyte esterase or white blood cells, the positive predictive value in detecting a urinary tract infection ranges from 4 to 30%. So even when you have leukocyte esterase, it's unlikely that this is a urinary tract infection. And that could cause you to say, here's a patient, come on, what do we do in the hospital? Every patient that comes in gets a UA. And then bam, you see leukocyte esterase in there, or you see white blood cells in there. The patient doesn't have any symptoms, but that white blood cell triggers them to order a urine culture. And so you might actually have worse use of laboratory resources and increased treatment of asymptomatic bacteriuria. Another problem is that there's no set of parameters that works well for all patient groups, just like there's no way to interpret urine cultures all the same and have it fit appropriate to all patient groups. There's no set of parameters on the reflex that work well for all patient groups. And this is just me, okay? But if we don't want to treat asymptomatic bacteriuria, then isn't the presence of symptoms a much better test than the UA in the first place? If you have symptoms, do the culture. If you don't have symptoms, don't do the culture. That works well, I think, in those patients who can actually tell you that they have symptoms. Obviously, in some patients, they're not going to be able to really verbalize their symptoms. And lastly, real quick here, I just thought I'd throw in a bunch of questions. This title here, Future of Urine Cultures, makes it sound like I know what's going to happen, but all I have here is a bunch of questions. What are we finally going to settle on for a colony count that's clinically significant? Or is that going to be different by different organism? Is it going to be different by different types of patients? So our job in the micro lab and interpreting these cultures might be becoming much, much more difficult, much, much more time consuming if we want to actually do something that's more clinically relevant here, which of course we do. Are we going to change our media conditions, our time? Will we ever have the space, money, and personnel to do that? We have to watch for that. And will somebody once and for all figure out how best to use UA to reflex to culture and whether it's worth it or not? I mean, every year you're going to see 20, 30 more papers that will argue about it. And we have never really come to a conclusion about it. And I don't want to give too much away, but at some point, are we going to completely get rid of urine culture altogether, or we can completely get rid of bacterial cultures altogether? That day is on the horizon. It will be after I retire. But yes, that's going to come someday. So that is all I have for you guys. I'm going to stop sharing here and look back at everybody, and happy to entertain any questions.
Dr. Junkins, this is Melissa. Previously, I had cared for medically complex patients. So, and some of those kids, there was a lot of colonization. There were frequent urinary tract infections. And some of those kids, we stopped doing UAs altogether because they always looked horrible, and we only did cultures.
Mm-hmm.
Some of these kids, they were chronically ill. Some of them had bladders sitting outside their body on their abdomen. And so it was really difficult sometimes to tell, when they're sick, is it from the bladder or from another source? So we had started for many of the patients, for the population, using things like NGAL to determine whether these were some of these were true infections or not. Do you see any benefit in using biomarkers? Is that done much outside of complex kids?
I don't really have any information on how well that is related to it or not. It sounds like something that should be beneficial, but I don't have any insight into how well that works. It is really difficult in complex patients to get good urines and really be able to interpret those well, though. I agree.
Thank you.
Sure.
I think we had a comment in the chat that we will make the recording available. People are saying, how can they use this to train others in their organization? So we can make this available. And also, if you, Dr. Junkins, are willing for us to be able to provide a PDF of your slide set so we can actually post that with the recording, sure. I think this is very helpful. And if somebody needs anything beyond that, you can always reach back out to me, and I can try to see what we can put together for them, if that works for you, Dr. Junkins.
Yep, happy to do whatever anybody wants.
Great. I'm not seeing any additional questions. Dr. Ramirez, I know that you always bring this home to what it means for clinical practice.
Well, no, this is, again, it's excellent. I think that Alan mentioned the complexity of going from a ambulatory patient with cystitis all the way to a hospitalized patient with pyelonephritis and septic shock due to urinary tract infection. Multiple questions. This is a moving target, this topic. This idea that in the hospital setting, these articles in the hospital setting, the bacteria is in the kidney, and then you're going to have really a urinary tract infection with a kidney infection that you're going to find antibodies attached to the bacteria, and then microbiologically, you're going to be able to separate what bacteria are in the urethra, the bladder versus bacteria that are coming from the kidney. I we want to be able at any point to figure out, I'm passing urine and this bacteria is really coming from the kidney versus just is lying there in the bladder.
Yeah. Well, from us, we look at, we don't know. I mean, if you have a whole bunch of, something in your urine, we don't know if it came from the bladder or from the kidney or where it came from. I would kind of consider that to say, you get into more invasive sampling procedures there, to what you can really get out. I hate to get into cystoscopy or I have seen urines that come to us labeled as kidney aspirates, so that would be the gold standard way to me, that I think that would be able to tell those. Otherwise, other than that, we're going to have to leave it up to you guys to kind of say, here's what we're culturing based upon the patient's symptoms and what other signs you see, as far as where is it coming from, bladder, or is it coming from kidney?
There is this, thank you. There is this thing that I never seen in any article, but I was taught during my training. The idea that if you get a urine from the patient, if the patient arrived to the hospital, you get a urine sample, and you get a drop of this urine, a drop of unspun urine, a drop of the urine. You dry it, and then you look at you do a gram stain. And if in this gram stain you see gram-negative rods, then you have more than 10 to the 5th colony-forming unit, because seeing 1 or 2 bacteria in an unspun urine translate into what microbiology is going to tell you in 2 days. How much of this is folk?
We must have gone to the same school, because I learned the same thing, that one organism on a high power field under the microscope is equivalent to about 10 to the 5th CFUs per mil. And I suppose you can kind of, you can calculate and see that that's probably, someone's probably done that. So yeah, I mean, it's possible to do. From a lab perspective, there's no way we're doing routine gram stains on urine. I mean, it's just impossible to do that many gram stains in one day. Plus, 1 per field is not something I'm really confident about. If I look around and I say, well, I'm seeing a few what look like gram-negative rods on there, I want to see more of it before I'm confident in saying, yes, there are gram-negative rods or gram-positive CAUTI or something here. So it would be a difficult gram stain to read and to report appropriately. The use of the gram stain, I think, might be better in situations where the culture results are kind of iffy. You don't know whether this bug is clinically significant or not. We're used to correlating gram stain to culture results when we talk about wounds or respiratories or something like that, but we don't do it with urines. But you could do it. You say, here's a bug that's growing on this urine, and I don't know whether it needs to be reported or not. I'm kind of iffy about that. You could take the urine, spin it down, look at the pellet, and do a gram stain on the pellet, and see if you see it in there. If you see it in there in a high quantity, if I see this gram-negative rod in a lot more concentration than the gram-positive coccus is, then I'll say, okay, I think the gram-negative rod is important here. So there's a utility for the gram stain in microbiology quality assurance. I don't see any utility of it really. Is certainly not a routine direct gram stain on urine. We get calls every now and then. People say, could you gram stain this urine? And we're just kind of like, yeah, no, sorry,
And you mentioned, thank you. Just last week, we're discussing a patient with candida in the urine. That then, at the end of the day, basically with a kidney stone. And then at the end of the day, the patient developed sepsis and was candida positive blood cultures. And there was a question, as you alluded, 10 to the 5th is coming from gram-negative rot in the urine.
Mhm.
And this is an old story from so many years ago. What is that in the case of Candida, that we come out with this 10 to the 5th is UTI, 10 to the 4th is not? Is this just something that we just translated from bacteria? Because now with some Candidas that are multi-resistant, that we don't know if the patient is colonized or not. What is and you already alluded that this cutoff, but you think that this cutoff from Candida 10 to the 5th is something that we just come out and say, well, you use bacteria, let's use Candida, or we have?
No, I think that's exactly what it is. I think we just picked 10 to the 5th back in 1957, and we've been using that ever since for any organism. And probably just like these papers that showed, maybe that's not a good cutoff for E. coli or Enterococcus or whatever. At some point, someone's going to look at Canada and say, at what point is it, what number is a good cutoff to use for Canada? We're probably going to have such a complicated workup procedure coming up here in the next 10 years or so that it's going to be madness for us. But yeah, it makes some sense that Canada would have a lower cutoff. And we do, we basically, even though we say 10 to the 5th is the cutoff, the clinically significant cutoff, we treat 10 to the 4th as the cutoff. If I've got 10 to the 4th E. coli, I'm reporting it doing susceptibility. So we kind of treat it that way to let you guys make the decision on whether this needs to be treated or not. Of course, we always put that comment in as well. For us, we put a comment in on every positive urine culture saying, if this is asymptomatic bacteriuria, I can never say that word. If this is asymptomatic bacteriuria, then it should not be treated. And Canada is the same way. The pharmacy people might be able to help out better on this, but my understanding is that the guidelines for treatment of candiduria is to not treat in most patients. Now, in your hospitalized patients who have all kinds of other problems, and then that's a different story.
No, Dr. Junkins, also this is a reminder that it may not be as relevant with Candida in the urine, but from a surveillance perspective, you may have an issue where the patient meets the infection definition that would need to be reported as part of NHSN and other CMS reporting. So this is another example that for the infection preventionist, it is not clinical illness that we are reporting. We are reporting, does the patient meet a clinical, a surveillance definition? So they may see differences, and then this may be something that, they will encounter where infection control has said this meets definition for this type of infection, but in the committee, someone may say, yeah, but no, that's all right, we didn't treat. Well, we are not saying it's clinical disease, we're saying surveillance definition. And so, this can be uncomfortable for IPs, but remember our responsibility is reporting in accordance with standardized case definitions.
See, that's why I thought twice about putting that part in there, because Ruth's going to get me on that.
No. It's not because it's perfectly appropriate. What we need to know is what does that mean because there's a difference, what that means to the infection preventionist practice. And what will that mean to the physician, advanced practice nurse, physician assistant practice? Right.
And that's why I kind of want our micro people to not know about those definitions at all. Because I don't want them sitting in a situation and say, well, look, if I find one more colony of something else here, if I look really, really closely at this plate, then it won't count as a CAUTI. And, we are doing what is clinically significant as far as infection goes. We're not doing surveillance, but you're using our data for the surveillance. So there's this overlap there.
Well, it's a pity that we went over time. I have so many other considerations, but you mentioned, Alan, that the urine, you agree that we used to call it sterile, and then we have the next generation sequencing and what is going to happen with urinary tract infection without with new detection. But a very interesting topic. Probably we have a part 2 or
Yeah.
nuclear tract infections in the future.
Yeah, I tell you, there's a lot to talk about with next generation sequencing.
Yes. Okay.
So,
well,
if I let me add one thing, if I can, Dr. Mears, if you don't mind. We are responding to a number of the questions from the IPs regarding, can we add the domain to the content so that participation in grand rounds then can be used as part of your submission for recertification. So as we add these to the YouTube website, in addition to having the additional resources, like, well, I'll add for Dr. Junkins the PDF, so you can use that for your presentations. But I'll also add the domain to this. So, for example, during today, we will be looking at surveillance of infectious diseases as part of this the domain, content domain for today. We are also adding, and I think Dave is going to put it in the chat, we are having a dry run for the skill stations that we will be showing at and having incorporated in boot camp. That will be the 4th, 5th, and 6th. Some of you may not be able to attend boot camp, but are interested in what these simulation experiences may look like, and we would love your feedback. So we will be having an open session, Zoom session, this coming Tuesday. I think it will last for 4 hours because we'll be going through a variety of these simulations. If you want to attend any or all of that, this will be an open Zoom link. You can come and go as you please. But we are doing this because we would like your feedback to see how well we're addressing this, and then how you think we can improve. This will ultimately be a CDC approved product and will be housed on the on a website then, providing continuing education credit. And you might also be interested in using this in your facilities for your training, since it'll be applicable to any setting where healthcare is delivered.
Then we want to thank Dr. Junkins for this provocative presentation, where he said at the end that probably we're going to drop urine cultures altogether. But he's going to expand on this in the urine culture parts 2. And we want to thank all of you for your attendance. And again, if you have any suggestion for topics for the future, please let us know. Thank you, Alan, and thank you all you for your participation. Thank you.
Thank you. Thank you.